Good morning, everyone. My name is Dr. Gorana Kuka Epstein. I come from Serbia. My background is plastic surgery, so I'm not a dermatologist, and I'm not someone who learned this by training. I sort of learned it while doing it. So I'm going to present a protocol that we use in diagnosing hair loss in women. I have no conflicts of interest. Sorry. Okay. So some important points to take home. Hair loss in women is very common. Is often multifactorial. It requires individualized workup, and also it's important to know when not to do hair transplantation. Facts are that 21 million women in the U.S. have some degree of hair loss. Textbook says that it's 40% of women experiencing hair loss before the age of 40. Hair loss often does not result from a single cause effect, but of rather combination of factors. And those patients are truly very grateful when properly managed and counseled. Why hair is important to every woman? It's a symbol of femininity, identity, freedom and beauty, liberation, and of course, youth. Etiology of hair loss in women, and I think other doctors are going to talk about that more. It's usually androgenetic, or now we more often refer to as genetic alopecia, alopecia areata, physiological stress, emotional stress, endocrine-related hair loss, nutrition, inflammatory infection, chemical agents, drugs, skin and or systemic disease, and much more. And that's why good protocol in evaluating these patients is critical. What we need during our consultation is detailed workup, attentive listening, because usually female patients really like to talk and to explain their condition, thorough examination, show empathy to your patient, and also to connect dots of what you heard from your patients. So here are the steps that we follow during our examination. Patient history, clinical examination, trichoscopy or dermoscopy, trichogram photography, hair test, lab evaluation, and often scalp biopsy. When it comes to patient history, here are some questions that we always ask. We ask about family history, personal history, and by that I mean the date when it started. They usually really know at least some period of time when they started noticing hair loss, periodicity, rate of progression, previous treatments they have done, dietary behavior, if they gain or lose weight, and associated symptoms, whether they have any redness, itchiness, or any other symptoms that might occur on their scalp. Medication history, like what medications they're taking, and also hair care history. When it comes to clinical examination, the easiest thing is to search for a pattern, and as it says, skill comes in making sense out what you see. These are somewhat typical patterns that I'd like to present, and that you also probably already seen in your office. This is a case of androgenic or genetic alopecia, alopecia areata. This is actually telogen effluvium, traction alopecia, scarring alopecia, and frontal fibrosing alopecia. So the first thing that you can look for are any sort of clinical patterns that you might see. Then, as far as examination goes, we do look in the quality of hair, quantity of hair, weight of hair, any scalp changes, and also changes on skin and nails, because they can also go with hair loss conditions. Very useful tool for me was when I learned how to do trichoscopy. What we look for when we do it is follicular patterns, vascular pattern, high diameter, hair diameter, and also skin surface. And when I saw this for the first time a couple of years ago, I thought it might be somewhat challenging for me to learn it, but then I found this book. It's called Atlas of Trichoscopy, where there is a very a detailed description of dermoscopy and clinical appearance. So I highly recommend this book for you if you want to start doing dermoscopy in your office. And trichogram is somewhat invasive test. We don't do it that much because it requires somewhat aggressive pulling of 50 strands of hairs, and then examine the root and the appearance of hairs that came out. Patients do not like it very much. I personally also do not like it, but it's another test to compare number of hairs in anagen versus telogen phase. Photography, I think it's critical. Some things you will notice once you take a photo that you might not notice while you're examining the patient. And also why it's really important is that you compare results while you're doing follow-up. You know, patients shows up in your office and you put him on a medical treatment, and then when she comes back in a couple of months, this is really the best tool to see what you have accomplished. Some of the tests that we do is a pull test. Pull test is basically test where you, on several areas of hair loss, you pull around 50 strands of hairs, and if more than 5 hairs come out, that means the pull test is positive, meaning there is some active hair loss in the area. Daily count test is something we do recommend. Sometimes women come and say, oh my God, I'm losing so much hair, so much hair, so much hair. And when you ask them how much, they don't know at times, so we do advise them to count them every day during the period of 7 days, so we know if that number is really above 100 or it's fewer than that. Hair breakage tests gives us explains us if hair is breaking, so whether it is really hair loss or only hair breakage. There is a tool called hair check device where you can check densitometry of hair, and it's a useful tool to compare hair density before and after the treatment. Wash test, part line hair width test, some tests that we don't necessarily perform in our office. Every consultation that I do consists of doing laboratory examination. I think it's mandatory. We do want to check if there is any disbalance in levels of iron, ferritin, vitamin D. And here is the panel that we do for hormones. So thyroid hormone levels, testosterone, DHEA, prolactin, estrogen, and progesterone. So the question is when to do those hormonal analyses. The answer is do them on the 3rd day of a cycle. In postmenopausal women, it doesn't really matter. When we are uncertain of a diagnosis, we do biopsy. It's 4 millimeter punch, 2 spots usually, and the thing is know where to biopsy. Cicatricial alopecia usually requires biopsy on the edge of the lesion. Milo and alopecia areata requires a biopsy in the center of the lesion. When it comes to androgenic condition, it really doesn't matter where you biopsy. I mean, it has to be in the area affected with hair loss. And then if you have a good path report, you can make a correlation with clinical findings. Most common reasons for visits are androgenic alopecia or genetic alopecia, alopecia areata, telogen effluvium, that could be acute or chronic, cicatricial alopecia, traction alopecia, and other conditions. Treatments, and I believe other doctors are going to cover that. Usually we prescribe minoxidil, finasteride, spironolactone in case of hormonal disbalance, steroids, laser therapy, PRP therapy, and something that is that we are exploring now are adipose injections. So when it's safe to do a hair transplant procedure in a woman, when you have naturally high hairline or frontotemporal recessions. When you do correction of scars, it's usually safe, although somewhat lower regrowth of graft may occur. when you have slowly progressive hair loss and good donor area, scarring alopecia or alopecia areata that has been stable for 2 years, also you need to have good donor area and realistic patient expectations. Always say no to acute telogen effluvium. So when there is active shedding, you don't want to do any sort of manipulation on that scalp. You don't want to provoke more shedding. When you have active scarring alopecia, alopecia areata, poor donor hair in cases of diffuse hair loss, and of course patients with unrealistic expectations. So listen, observe, test, follow diagnostic steps, and also the way how I learn the most is from my follow-up. So to see what works in certain patients, how patients respond to treatment, whether they're committed. That's the first question asked. How committed are you going to be to this therapy? Because if someone needs to put minoxidil every day, you really want to make sure that that person is going to be doing that, because they come back to you saying, oh, I've used it. Okay, how did you use it? I use it once a week or twice a week. That wouldn't really work. For me, I started with hair transplantation surgery, and then I expanded to this field. I think it expanded my expertise. It's very rewarding for me. Women are truly good, eager, and appreciative patients, and for me, it's an interesting field of medicine. Thank you.